Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics seminar series. My name is Andrea Bianchi, and I'll be the moderator for today's session. Our speaker today is Dr. Jeffrey D'Souza, and this seminar is entitled Cervical Cancer, Vaccine Equity, and Global Solidarity, Fighting for the Health of Women and Girls. Before I introduce today's speaker, I'd like to let you know that this seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now it's my pleasure to introduce today's speaker. Jeff D'Souza holds a Ph.D. in philosophy from McMaster University, a Master of Arts in Philosophy from Toronto Metropolitan University, and a Bachelor of Arts in Political Science and Philosophy from the University of St. Michael's College at the University of Toronto. His formal academic training is in Neo-Aristotelian virtue ethics, and his current research focuses on research ethics, health equity, and global health ethics. Jeff has worked on a wide range of health and ethics-related issues with partners across the globe, and is actively working on projects related to cervical cancer elimination, malaria elimination, the ethics of research priority setting, and the interconnectedness of research ethics, climate change, and global health. Jeff, on behalf of the JCB, welcome to today's seminar.
Good afternoon, everyone. And thank you, Andrea, for the kind introduction. First off, I would like to thank the Joint Centre for Bioethics for the invitation to be here. And thank you all for attending. Today, as Andrea mentioned, I'll be sharing with you a research project I've been working on for the past year or so, tentatively entitled Cervical Cancer, Vaccine Equity, and Global Solidarity, Fighting for the Health of Women and Girls. So I hope everyone can see my slide deck there. So I'd like to begin with a little bit of an acknowledgement. So I'd just like to take an opportunity to thank all those individuals who have helped contribute in some shape or form to the ideas presented today. In particular, I'd like to give a special acknowledgement to a colleague and friend of mine, Dr. David Nadirtu, who we see here on the slide. Our previous publication, just on the right here, was really the launching pad for the presentation today. And so I'm deeply indebted to him for this presentation and today's work. Okay. So here's a rough outline of my presentation today. I'm going to start off by providing a very high-level background on cervical cancer and cervical cancer elimination. For those who are familiar with the global cervical cancer elimination effort, my apologies, but I really wanted to try to get all of us up to speed before jumping into my ethical framework. Next, I'll turn to describing the current context at hand and what I believe to be a significant opportunity before us, and in particular, provincial, territorial, and federal governments to do something meaningful to help eliminate cervical cancer globally. Then, number 3, I'll lay out an ethical framework to help guide the deliberations and actions of those individuals who may have to decide what to do if the Canadian National Advisory Committee on Immunization, also known as NACI, changes their recommendation from a 2-dose HPV vaccination schedule for girls 9 to 14 years of age to a single-dose schedule. And then finally, I'll talk a little bit about how we all, and in particular our governments, might go about playing a greater role promoting vaccine equity and helping in the fight against cervical cancer elimination. My goal is to get through this presentation fairly efficiently so that we have lots of time for discussion and questions at the end. Hopefully, or ideally, I'd love to hear from each and every one of you. So please don't hesitate to drop your questions into, I think, the chat as they arise. Okay. So let's jump right in. So before getting into discussing cervical cancer elimination, I wanted to take a minute to step back and talk more broadly about cancer and cervical cancer. And this is because sometimes I find that we tend to talk about cancer as if it was just one particular disease, when in reality, there are more than 100 types of cancer, which is way too many to recite here. We also sometimes talk about cancer in terms of generalities and say such things like there is no cure for cancer, and may even tend to view an early stage cancer diagnosis as the worst possible news. Now, while this may be true for many types of cancer, these ideas don't transfer to very accurately to cervical cancer, which is entirely eliminable. Now, by eliminable, or when we talk about cervical cancer elimination, I don't mean that no woman ever gets diagnosed or dies with cervical cancer from cervical cancer, but rather that we get to a place where all countries reach and maintain an incident rate of below 4 per 100,000 women. And this is a definition provided by modelers to prevent cervical cancer as a public health problem, and has been adopted and endorsed widely by the WHO, for example. Okay, so cervical cancer wasn't always eliminable. And so what you see here is a very high level timeline. So in the 1800s, we really only had a suspicion that sexually transmitted agents cause cervical cancer. Fast forward, use my cursor here a fair bit. In the 1980s, we learned that a select group type of HPV is responsible, for the majority of cervical cancers, and that's HPV type 16 and 18. In 2006, the first HPV vaccine is developed and is approved by the FDA and authorized by Health Canada, and that's with a 3-dose schedule. 2008, the HPV vaccine was approved in more than 80 countries. In 2009, the WHO recommends routine HPV vaccine for all girls 9 to 14 years of age. In 2015, the suggestion is made that a 1 dose may be sufficient for girls 9 to 14 years of age based on follow-up data from clinical trials. And in 2016, countries moved forward on a 2-dose regimen, citing non-inferiority between 2-dose and 3-dose schedules of the HPV vaccine. Now, this is all to say that in the past 30 years or so, the global community, and this includes researchers, the pharmaceutical industry, nonprofit organizations, policymakers, and governments, have really harnessed the power of the HPV vaccine. And this is in part because the vaccine is very, very effective at preventing cervical cancer. Oh, hold on here. Did I miss a slide? Okay. So okay, so sorry about that. Just finding my notes here. In 2018, over here, we get the establishment of the cervical cancer elimination as a global health priority, adopted by the World Health Assembly and endorsed by the WHO. And then in 2020, we get the strategy for the elimination of cervical cancer. Okay, here we go. Now, I just wanted to take a moment and acknowledge that none of this would have been possible without Henrietta Lacks, which some of you, I'm sure, will have heard of. In 1951, Henrietta Lacks developed cervical cancer, and after treatment, her cells were used in research without her consent. And those very same cells helped connect HPV and cervical cancer, which led to the HPV vaccine. And for any of you who work or teach research ethics, her name and her story is one that usually comes up when we talk about egregious research ethics violations. And her family has played a role, and as we can see here, have decided to become ambassadors for cervical cancer elimination. Okay. So when we take a closer look into the global strategy for the elimination of cervical cancer, we see 3 major targets. The World Health Organization calls for 90% of girls to be vaccinated by 15 years of age, 70% of women screened, and 90% of women treated with precancer and invasive cancer. And this is what it would take to eliminate cervical cancer as a public health problem. And while the focus of this presentation is on HPV vaccine equity, we know that cervical cancer elimination also crucially relies on ensuring that women are screened with a high-performance test by 35 and 45, and that women also receive treatment for precancer and invasive cancer. And this is because while HPV vaccines are highly effective at preventing those strands of HPV they target, HPV vaccinations are only able to prevent approximately 70% of cervical cancer cases. And this is why screening and treatment are also so important. Now, if we're able to achieve the 90, 70, 90 targets by 2030, this would mean that we would be able to prevent 5 million women and girls dying from the disease by 2050 and prevent 62 million cervical cancer deaths averted by 2120. And I kind of want to repeat that again so that these numbers actually sink in. So if we are able to meet the global targets set out in the cervical cancer elimination plan by 2030, this means that 5 million deaths will be averted by 2050 and 62 million deaths by 2120. So despite having the tools to eliminate cervical cancer, the stark reality is that the burden of cervical cancer is concentrated in low and middle income countries, and primarily on the continent in Africa. We see that 604,000 new cases of cervical cancer a year and over 342,000 deaths per year, which translates into every 2 minutes, one woman dying from cervical cancer. And to make matters worse, those who need the vaccine most have least access to it. So we know that 90% of the burden of cervical cancer is in LMICs, low and middle income countries. And we see that 30% or less of low and middle income countries have HPV included into their national immunization programs, where high income countries and upper middle income countries are doing much, much better. And in Canada, you'll see from coast to coast to coast in all provinces and territories, girls 9 to 14 years of age have access to the HPV vaccine, and this is usually done through school programs. Okay, so one of the odd things about working on global cervical cancer elimination during the global pandemic was that I found myself asking why. Why is it that so many people seem to be talking about global solidarity, vaccine equity, health equity, when it comes to COVID-19, when it comes to the COVID-19 vaccine, but not with respect to other vaccines, such as the HPV vaccine, the project that I was working on. And this is especially peculiar when we take a look at the burden of disease. And so this is a map of total deaths related from COVID-19 for all countries across the continent of Africa since the beginning of the pandemic. And in the past 3 years, there has been 256,542 COVID-19 deaths, or reported deaths. Now, even if we take the number from COVID-19 deaths and say multiply it by 3, let's just assume that the actual reported number is much lower. This still means that more people died from cervical cancer on the continent than from COVID-19 during the global pandemic. And it also seems to me, especially if you want to be consistent, that morally speaking, if we care about vaccine equity with respect to the COVID-19 vaccine, we should equally, if not more so, care about vaccine equity with respect to the HPV vaccine in light of these statistics. And perhaps an interesting point that we might want to come back to in the discussion period is exploring why this might be. I have some thoughts, but obviously would love to hear from each and every one of you. Okay, so that's the background, and I'm going to transition into the current context. Okay, so recall, in order to eliminate cervical cancer, we need to ensure that girls 9 to 14 years of age are fully vaccinated against HPV. Also recall, based on our timeline, that in 2006, this meant that girls needed to receive 3 doses of the HPV vaccine. And then in 2016, this shifted to girls only needing 2 doses of the HPV vaccine, even though in 2015, there were suggestions being made that a 1-dose HPV vaccine might be enough. Fast forward to April 22, and at the World Health Organization Strategic Advisory Group of Experts meeting, leading scientific experts from around the world reviewed the evidence in favor of a 1-dose regimen and concluded that a 1-dose HPV vaccination schedule provided a high level of individual protection against cervical cancer, similar to 2-dose and 3-dose regimens. And so in light of the evidence, they changed their recommendation from a 2-dose schedule for girls 9 to 14 years of age to a 1 or 2-dose schedule for girls 9 to 14 years of age, emphasis on the or. Now, while this might not seem like a big deal, I was at that virtual meeting, and I personally got the sense that there was such an excitement on the call for what this new recommendation would mean for cervical cancer elimination. The decision has since been described by the World Health Organization as a, quote, game changer, because it essentially means that we can fully vaccinate women and girls with half the amount of doses. Now, in light of the WHO's recommendation change, governments around the world have had or will have to decide whether to offer a 1-dose HPV vaccination schedule or a 2-dose vaccination schedule for girls 9 to 14 years of age. And in previous work that Dr. Nadirtu, David, who I referenced earlier, and I have done, we laid out some guiding principles to help policymakers decide whether they should opt for a 1-dose or 2-dose regimen. And we published this piece last year. It's accessible, so I won't get into it now, but obviously happy to come back to it during the Q&A or discussion period towards the end. Okay, so as a result of the World Health Organization recommendation change with respect to the HPV vaccine, the Canadian National Advisory Committee on Immunization, NACI, their next project is to review the effectiveness of a single-dose HPV vaccination schedule for girls 9 to 14 years of age. And this was in fact triggered by the WHO recommendation change. And while it's unclear when exactly we will receive a decision from NACI, we can expect one in the not so distant future. Now, if I had to venture a guess in terms of which path or which direction NACI might go in, I think the most likely outcome for NACI is to make the recommendation change from a 2-dose vaccination schedule for girls 9 to 14 years of age to a 1 or 2-dose vaccination schedule. And this is a decision we can see here that the Joint Committee on Vaccination and Immunization, and that's the expert scientific advisory committee, which advises the UK government on vaccine policy, has already made. And really, when we look at the evidence in favor of a 1-dose regimen, it really is quite strong and is trending to get only stronger and stronger. Okay, what should governments do? So assuming in the next year or so, NACI makes a recommendation change from a 2-dose HPV vaccination schedule for girls 9 to 14 years of age to a 1 or 2-dose HPV vaccination schedule. Provinces and territories would then require half the number of vaccines to protect girls 9 to 14 years of age from cervical cancer. In such a situation, Public Services and Procurement Canada would then renegotiate or adjust their future contracts based on the reduced demand of the provinces and territories. And with that reduced spending, the provinces and territories really have 3 options. So the first here is they could simply, spend less money. The second is they could redirect those monies elsewhere or put the money towards other sorts of things. Or third, they could use those monies they put towards fighting cervical cancer domestically toward fighting cervical cancer globally. And I'm sure you all have a sense in terms of which direction I'm going to lean. Okay, just going to check the time here and see if we're doing okay. Okay. Now, many of you might think this might be an odd slide or quote to put in a presentation on cervical cancer elimination, but it really does resonate for me. So when we talk about what governments should do in the event that provinces and territories decide to opt for a 1-dose regimen for girls 9 to 14 years of age, the question really isn't important. And as Socrates reminds us here, we're talking about how we collectively should live, right? Our thoughts and our actions affect others. And based on what we decide in this particular case, either additional girls will have access to life-saving vaccines or they will not. And for me, morally speaking, the answer is pretty clear in terms of what we should do. So if our central ethical inquiry is what should provincial and territorial governments do, morally speaking, with the savings associated from a single-dose regimen, the answer is provincial and territorial governments should donate the excess monies to establish procurement channels, such as Gavi, the Vaccine Alliance, or UNICEF, where the money can be put to providing HPV vaccination schedules for girls most at need. Now, why do I think we should donate those excess monies to fighting cervical cancer elimination? Well, for me, three principles come to mind. So beneficence, stewardship, and solidarity. Let's take a look at each of these in turn. Okay, so out of all the potential things to do with the money related to the cost savings associated with switching from a 2-dose schedule to a 1-dose schedule, donating that money to established procurement channels will have a huge impact on eliminating the burden of cervical cancer. So whether we look at DALYs or QALYs, vaccines compared to screening and treatment have a huge impact, and organizations such as Gavi do a great job and have a long track record of working with communities to ensure that vaccines get to those most in need. And this is really where 90% of the burden of disease is, right? This is the primary prevention. Okay. So the next principle, stewardship. So one thing that we do know about the price of a single dose of the HPV vaccine is that the price varies greatly. Some established procurement channels, such as Gavi, are able to purchase a dose for $4.50 American dollars on behalf of low and middle income countries, whereas a single dose purchased, for example, privately in Toronto can cost over $200. Now, unfortunately, the exact amount that Public Services and Procurement Canada is able to purchase the vaccine for through the bulk purchasing program is confidential. But I think it's fair to assume that we'll be able to purchase many more vaccines through Gavi than through the Public Services and Procurement Canada, allowing for an even more responsible use of public health dollars. And this will obviously enable many more girls to have access to an effective HPV vaccination schedule. And this will mean that for every dollar donated, the number of girls who will have access to an effective vaccination schedule will be greatly increased. Okay. So solidarity. As mentioned, cervical cancer elimination requires that 90% of girls in all countries are vaccinated. And this is not just Canada. Solidarity requires that we care about women and girls, not just here, but abroad. And that we just don't talk about the importance of, for example, solidarity or feminism or the health of women and girls, but that we also act accordingly. We have to walk the talk. In this particular case, it's not that provincial and territorial governments simply don't have the budget to do more to eliminate cervical cancer. And the ask isn't for provinces to spend or territories to spend more than they're already spending, but rather, instead of fighting cervical cancer just domestically, they also fight it globally. And so as I see it, there's no real excuse for the provinces and territories to say they don't have the funds or the means to do it, because right now they're spending that money anyway. So in summation, right, in response to what should provincial and territorial governments do, morally speaking, with the savings associated from a single dose regimen for girls 9 to 14 years of age, I contend they should donate to established procurement channels, whether it's Gavi, the Vaccine Alliance, or UNICEF, where vaccine access can go to girls who need it the most. Why? Well, it will do a lot of good. It's a great use, optimal use of public resources. And we owe it to women and girls as a matter of solidarity and justice, and to people across the world. Okay, oops. Okay, so what I've just presented are 3 principles aimed at grounding, let's call it a prima facie duty for provinces and territories to use any cost savings associated with switching to a 1-dose regimen at home to fighting cervical cancer abroad. But there are, of course, many moral arguments that may be given. And some of you, I imagine, might recall this argument from Peter Singer, sometimes referred to as the other Peter Singer in Toronto circles. And it just goes like this. If it is in our power to prevent something very bad from happening without thereby sacrificing anything else morally significant, we ought morally to do it. And no doubt I can list other moral arguments based on the right to health. There's also John Rawls's most important natural duty, and I'll just read it here, which states to assist in the establishment of just arrangements when they do not exist, at least when this can be done with little cost to ourselves. And I could go on with a litany of other moral arguments in favor, but we'll stop here. And of course, we can come back to this once again during the discussion period if you want to explore other arguments further. Okay. And yesterday, actually, in my local newspaper, I tried to make the case by making more of a democratic argument. And essentially, my argument was that this is what people living in Canada, I think, want. And so I write here, such a move would be in keeping with Canadians' values in terms of the cost effectiveness of such a decision, the focus on health equity and solidarity, and the emphasis on gender equality. And we can also talk about the difference between democratic and philosophical or ethical argument as well later on. Okay, so I'm just about to wrap up here. Okay, doing good on time. So how might this work? So I've made the moral case that the federal, provincial, and territorial governments should use those monies associated with a potential shift to a one-dose regimen to fighting cervical cancer globally. Now, such a call to action, of course, requires collaboration, but the kind of collaboration that is needed is not new. Money changes hands regularly among provincial, territorial, and federal governments. And as we see here, Canada has a track record of donating money to Gavi, and more specifically, has previously donated money to Gavi for promoting equitable access of the HPV vaccine for girls in need. So working out the details, while of course will require some work, is not a major obstacle or something out of the ordinary. Now, ideally, were Canada to take such a bold step in terms of utilizing cost savings associated with a one-dose schedule and using those monies abroad, it could hopefully create a ripple effect where other high-income countries do the same. That is, donate their cost savings associated with a switch to a one-dose regimen to girls in need of the HPV vaccine. And when I reflect back on the past 3 years, reminding you all that I've been working on this through a global pandemic, and I see the type of collaboration that took place to not only develop a vaccine against COVID-19, but also the establishment of COVAX, which, as you can see here, is supposed to be a support for the equitable access of vaccines against COVID-19. And we can talk about that in the Q&A too, if people want, in terms of how effective it's been. But there's no good reason, in my opinion at least, why high-income countries cannot do the same to help ensure that all girls everywhere have access to an HPV vaccine, especially in light of, the math that I showed earlier in terms of the effect of COVID-19 on certain countries versus the effect of cervical cancer. So as hopefully has come across, I am winding down, cervical cancer elimination is within reach. And Canada will be in a position to do much more in the fight against cervical cancer elimination. Part of what I tried to do with this particular research project is bring awareness of a unique opportunity that the federal, provincial, and territorial governments will have if/when the recommendation change from NACI is made. I think that we missed the boat when provinces and territories shifted from a 3-dose regimen to a 2-dose regimen. And my hope is that we don't miss the boat again. At the very least, I want to ensure that the Minister of International Development's office is aware, so that at the very least, they can make an informed decision whether to support this idea or not. And this opportunity is obviously one that I think all provincial and territorial governments should be aware of, right? They'll all be in this, well, as I foresee things unfolding, they'll all be in a position where they'll have to decide, what do we do after we switch from a 2-dose to a 1-dose? Okay. So how can we join in the fight to help women and girls susceptible to cervical cancer? So we can obviously help raise awareness. So there's Cervical Cancer Elimination Day of Action, November 17th. We can partake in Cervical Cancer Awareness Month in January. We can donate to, for example, Gavi or UNICEF. And we can write to, ministers. We can write to our MPPs. We can write to our MPs. And we can, ask for them to sort of do more. And I'm not sure, how many of us it will take for perhaps, decision to be made to do more. Maybe we won't need to do anything at all. And this will come across their desk and they'll just, go for it. But we can always sort of, use our collective voice to produce action. Okay. So that brings me almost to the end here. What I want to do is I just want to see if I can play one short video. So bear with me as I set that up here. Do we have that? Okay. Maybe it won't let me. I'm just going to stop sharing for a second. I'm not sure if that's okay, Andrea, and then I'll reshare. Let's see if that works.
Of course, let's see if it works.
Okay, thanks. I had it somewhere, but I don't know where it went. Okay. I just want to check. Are you able to see the video, Andrea?
Right now, I think just because you're not sharing your screen, I can't.
Okay. Okay, perfect. Let's see if that works.
Yeah, I think you're good to go.
I represent survival in life today. I represent it.
Today, we're calling on all countries, all manufacturers of vaccines, tests and treatments, all partners, and all civil society organizations to join us in our effort to make cervical cancer history.
So the continuum is intact. The tools are available. They need people, they need resources, and they need very dedicated expertise at the delivery level. So we must continue.
To commemorate the day, we are continuing our engagement with local partners to support free cervical cancer prevention services for marginalized communities here in Miami.
Healthcare workers, medical students, nurses, and doctors from all around the country took a pledge to promote cervical cancer elimination and move towards the goal.
Our government has just announced funding that will make self-collection of the sample for the cervical cancer test universally available.
You're the ones who can make the difference, so do it.
People are stopping hair loss.
I'm not sure why that advertisement came up. YouTube might be onto something here. Okay, so let me just see if I'll continue on. So that really, so that really wraps up the presentation. Just wanted to say I have no conflicts of interest to declare. Just some resources I used, and I just wanted to thank you all very much for your time. And I'll stop sharing there.
Amazing. Thank you so much for that wonderful presentation, Jeff. That was insightful for me. I certainly didn't know a lot of the content that you had shared initially and the stats. And so very insightful for myself. And I'm sure everyone who's currently attending in and will tune in afterwards as well to the video. So it is time for the question and discussion period. And so I would encourage those who are on YouTube right now, if you do have a question or a comment, a thought, something that stood out to you during Jeff's presentation, please feel free to put it into the YouTube chat. If you aren't logged into YouTube or for whatever reason you wish to ask a question anonymously, you can send your question to jcb.ea@utoronto.ca. I believe that's been put into the chat in YouTube, so you can copy and paste it as well. And so I would encourage you to certainly do so if things are on your mind from the presentation. And perhaps to kick things off, and this is something, Jeff, that you had mentioned toward the beginning of the presentation, just the discrepancy that exists between, or that existed between our call for vaccine equity in relation to COVID versus that of cervical cancer. And you put those astounding stats on the screen regarding the number of people who have died in regard to this. And so I'm curious, you mentioned that you certainly do have some thoughts and theories as to why this discrepancy may exist. I would love to hear them. And I'm curious as to whether just the fact that COVID, is very much a topic that's on everyone's radar. Is everywhere on the news. Is that part of it? Just what are your thoughts?
Yeah, so that's an excellent question. Like colonialism, in a word, kind of comes to mind, or Western supremacy, or just the very fact that cervical cancer deaths aren't as prevalent in the global north as they are in the global south. And so that perhaps is one thing that came to mind. The second thing is also maybe being kind of like a prisoner of the moment. So, here's this new virus, COVID-19, that, enters into the scene, whereas cervical cancer has been something that's been going on for a long time. Also, racism comes to mind. What do the people look like who are suffering, right? But when I showed that map there, a lot of this is taking place, and a lot of the people who are suffering from cervical cancer live in the global south. I think my stat here says that 410 women in Canada die from cervical cancer. That's not a lot compared to a lot of other countries. And so, the burden of disease here, and we're also, I think generally speaking, we tend to sort of focus and, pay primary attention to, what's happening in our kind of, community, province, country, and not sort of, look at what's happening elsewhere. So those are just some thoughts that come to mind, but it was rather peculiar that there's so much collaboration and so much sort of coming together around COVID-19, but not so much with other things that, still affect women here. So it's not to say that, cervical cancer isn't something important to be tackled in Canada. It absolutely is. It's just that the emphasis on solidarity and vaccine equity, it just wasn't the same. Yeah.
Thanks. I really appreciate you sharing your perspectives and your own theories, which seem unfortunately quite plausible. To me, certainly, Jeff. So thank you for sharing that. And some questions are coming in. So one person is just saying thank you for the presentation. Can you comment on HPV vaccine equity in relation to boys or men, and in particular, men who have sex with men?
Yeah, absolutely. So this is a great question. So really, I'm coming off a cough, I apologize. So really the focus of this presentation was centered around one specific question, which is what do we do in the event that NACI makes a recommendation change and then provinces and territories find themselves in a situation where they're able to, pay for less vaccines. What should they do with that money? And so my thought is, okay, well, we give it to, there's a responsibility to give that money to fight cervical cancer globally. I didn't talk at all in this presentation about people outside of the 9 to 15 age group. Now, from a public health or from a population health perspective, the reason why that's so important is because that's generally speaking the time before sexual debut. And so, HPV is transmitted sexually. And by tackling this particular age group, we're able to provide significant protection to the girls as they age. And there's also lots of indirect effects that we see, for example, for boys. If there's less women with cervical cancer by vaccinating girls earlier on, then there's an effect indirectly in terms of community spread. In terms of so the recommendations, the major what I've described as a game changer that really applies just to the one dose recommendation for girls 9 to 15 years of age. The recommendation change for there hasn't been a recommendation change for men who have sex with men, for women who are above a certain age range. So I think it's like so that they're still recommending 2 to 3 doses depending on kind of where you are. What other sort of bucket you kind of fit in. So in terms of vaccine equity there, that's actually a really good question. And I don't have an answer for this individual who asked the question in terms of vaccine equity there, but I would suspect that there will still be some vaccine equity, but the focus of this talk was obviously on cervical cancer. So I'd have to look into that more to be able to get back to that person.
Thank you so much. And perhaps if that person is interested in learning what resources or connecting with you about it, then they can send us an email. We'll connect you happily. Another question came in, Jeff, just around responding and how might you kind of respond to someone who could argue or who might argue that the cost savings that results from the one dose regimen, this idea that maybe the cost savings should actually be redirected to underfunded health programs for Canadian women and girls versus overseas, and just what your thoughts might be about that.
Yeah, so it becomes a lot trickier, when you're talking about giving to one noble cause versus giving to another noble cause, But I think that in this particular case, if you look at DALYs and QALYs, so disability adjusted life years, and if you look at the type of health enhancements that you're able to produce, and if you start off with this fundamental when you start off with an initial or underlying premise that all lives have equal value, and that a person living in, for example, Zambia has just as much right to access to cervical cancer vaccine and someone living in Canada, it's really hard to sort of move away from that. And so the first thing I would think of is, okay, well, can we do both? Are we able to find money to address this particular need? And there is no shortage of needs in Canada as well, right? There are tons of needs. And important ones that we should be, I think, spending more money on. But I think that here's helping to provide access to the cervical cancer vaccine in low-income countries. I think that's a huge priority there. And that one staggering quote, I don't have it up right now, but on just the number of deaths that will be averted, we're talking about millions and millions of people, right? That's that's a lot. And so at some point, perhaps it comes down to a numbers game. But my initial thought is, okay, well, how can we find a way to do both? Yeah, that's where I leave. But I think that's a great question.
Thank you so much. Another question is just around your comment related to COVAX, and that, you know, it's supposed to be kind of supporting and fighting for vaccine equity. And if you can say a little bit more about the efficacy of COVAX and why perhaps you had stressed, right, like that it's supposed to do this.
Yes. So I think, you know, depending on who you talk to, maybe it was more of a success or more of a failure. So I have been on some calls in the global health space where when people are starting to reflect on what went wrong or what could we do better for the next pandemic, feels weird to talk about that already. One thing that always comes up is equity, that we still left people behind. And so here we had this initiative that was supposed to promote health equity. In reality, did it? Maybe more than it otherwise would have, but perhaps not enough. So I say supposed to because I'm not 100% sure whether it actually did or not. Yeah.
Thank you.
But that's an excellent question. Yeah.
Yeah, no, it's great. There's lots of excellent questions, in my opinion, certainly coming in. Another one, and it says, as a follow-up to the first question, I'm not sure whether this was the first question of all the questions or just the one that was posed, but either way, there's an idea put forward here for your consideration, which is this idea that vaccinating others against COVID, it's also protective. And so there is an element of self-interest in preventing COVID, but not the vaccine for cervical cancer. Or perhaps that is supposed to extend to, you know, is also protecting other people. Perhaps that is where that part of that question was going, whereas that same rationale or connection maybe does not exist when it comes to cervical cancers. And if you need a follow-up then or want clarification, then we can ask if that person can just provide a little bit more.
Yes. So from what I heard there, it's more of a thought than an actual question. And I think I'm somewhat sympathetic, I think, to that idea, that this idea of transmissibility might play a role in terms of why we emphasize or why we pay more attention to some vaccines than others. So for example, we're not so much worried about, so there are, you know, hundreds of types of HPV, and there's really only 2 that are responsible for 70% of the cervical cancers. And so we're not as worried about, you know, various types of mutations, and then them being able to sort of overcome the current vaccine. And so maybe the threat to the individual is less from HPV 16 and 18 versus COVID-19, Delta, or pick your variant. And so I'm sympathetic to that. That could perhaps be playing a role. For sure. Unfortunately, self-interest or national interest or what have you often sometimes comes at the expense of, you know, doing what's best for everyone.
Yeah, thank you. And you're bang on that it was certainly an idea put forward, and very much appreciate your comments in relation to it. Another question came in that is somewhat of a practical question, but I think that there is an important ethics lens and considerations here to take into consideration. So the question is, are there any differences in efficacy between the one-shot vaccine option and the two-shot option? Why was there a shift in recommendation? Was there an improvement in the actual vaccination? And so I think in expanding beyond that, I wonder if you could talk a little bit about how decisions are sometimes made when it comes to these NACI recommendation changes. Was part of the recommendation, or was it exclusively based on an improvement, or was it also based on resource allocation challenges, wanting to have more available to disseminate amongst a larger number of people?
Yeah, that's an excellent question. So when you go back to that timeline, right, really we have the first vaccine arrive in Canada in 2006. And so for some of the early clinical trials, there were people who were lost to follow-up. And so we were able to have observational data from some of these individuals. And so we have some evidence, but really it wasn't until the initiation of certain randomized control trials, the gold standard, that are still ongoing, but it's sort of based on interim data that we're sort of able to say, okay, this single dose provides a high level of individual protection for girls from cervical cancer. And, you know, these studies are all ongoing. And as girls, and, you know, the HPV vaccine is offered to girls in that early time frame, but lots of women don't develop cervical cancer. Like if you look at the screening and the test, the screening, it's usually at age 35 and 45. So we have to wait a few decades to really, you know, have more certainty in terms of, okay, well, just because maybe at age 20 or 22, there's no signs of cervical cancer, how effective is that one dose, you know, 20, 30, 40, 50 years down the road? And so at the Strategic Advisor Group of Experts meeting, they looked at all the evidence. They looked at the observational stuff, so people who are lost to follow-up. They looked at the randomized control trials. They looked at all the different markers for protection. And really, it was sort of this global kind of take, and it was based on individual protection. Right now, all, whether 1 dose, 2 dose, 3 dose, they're all showing signs of 97% plus effectiveness against cervical cancer from the strands they target, so HPV 16 and 18. And then there was mention about resources. So the shift to the 1 dose is also less resource intensive, which would enable and allow for countries to focus on screening, to focus on treatment, to focus on other health-related challenges. And then the third, so the resources, and the third is to allow for greater population coverage. So we would be able to vaccinate more people with less vaccines. So those were kind of like the 3 main ideas that I heard when I was at the meeting. And those are the 3 kind of big ideas that are usually cited. But the evidence is still coming in. And also there's a whole bunch of side things that were also mentioned that are also important to consider. So I do know, for example, the UK government or their advisory committee, what they are recommending is also that we continue to monitor cervical cancer incidence rates, because if it turns out, you know, that, well, maybe after a certain amount of time, the 1 dose isn't as effective, then okay, well, maybe we need a booster. And for those of us living in this global pandemic, we know all too well about boosters, right? Like they exist and they serve purposes, and sometimes they're needed, right? Yeah, but that's an excellent question as well. Yeah.
Thank you so much for sharing those insights around the decision making.
Also, so the other part of that question, I apologize, Andrea, is so I can't speak to what goes into NACI's decision. I imagine it would be something similar. I'm not privy to that, so I have never attended a meeting, or I've never, I don't know somebody who has, and so I can't really speak to what would go into their deliberations. I imagine first and foremost, it would be the scientific evidence, right? So what is the immune response, right? The antibodies, the T cells, like all of that stuff would be looked at, all of the clinical trial data, all of the stuff that the WHO looked at, that the UK looked at. I imagine it would be very similar.
Yeah, thanks so much for sharing your insights and experiences in terms of how these decisions can be made, perhaps within NACI, but certainly beyond, and that it is incredibly evidence-based, and that there are all these other considerations. Also taking us through the history there, that's incredibly helpful, Jeff. And unless there are any final kind of last minute questions, I encourage you to use your fingers wisely and type fast. But with that, it is 4:55, which is incredible, a wonderful Q&A duration, which I think speaks to just how thought-provoking and important and insightful your talk was, Jeff. And so I will bring this seminar to a close now. And I have a couple of announcements to make, and then certainly want to close off by just formally thanking you again, Jeff, for sharing your insights. So for everyone who's here today, want to let you know that our next seminar will take place next week on April 12th, and this will feature Dr. Nathan Robert Howard and Dr. Eric Matheson. The seminar is titled How Informed is Informed Refusal. And to sign up to receive weekly seminar reminder emails, please feel free to email jcb.info@utoronto.ca. And this should be put into the chat as well in YouTube, so everyone can copy and paste it. And of course, CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And so on behalf of all of us, Jeff, I certainly learned a lot and thought a lot throughout the duration of your talk, and will continue to do so because of it. And I want to thank you very much for presenting as part of the seminar series. It was a pleasure.
You're most welcome. Thank you for the invitation once again.